Right, when this started and how big it is, the two pieces of information, when was the last known well, and whether or not this is a large vessel occlusion, is important because it makes a big difference in what treatments the people get. Maybe not so much from you, because we're going to treat most of these people kind of the same way in terms of things that we give them, but not entirely. Once you get a little farther down the line, though, to an emergency department or something like that, then things are quite a bit different. So there's two main treatments for stroke other than just kind of rehab. Number one, we have the thrombolytics, the TPA. TPA is relatively easy to do. You got to basically be able to mix it up. You got to get the weights right, and you got to give the time. You got to get the timing of it right. But for the most part, it's something that an emergency department, pretty much anybody can kind of do. It's not particularly hard. So like a primary stroke center can do this. An acute stroke ready hospital can do this. Most EDs, even if they're not stroke centers or anything like that, with appropriate consultation, it's basically just giving a drug and then transferring them to a neuro ICU. It's not a super hard thing to do. So it is widely available to most folks. The problem with it is that you only have about 3 to 4.5 hours, as I've kind of mentioned, after the last known well time to get it started. And that can be really difficult to get started in folks. So that's why there are systems set up in order to move people quickly straight to the scan to make sure they don't have a bleed, and then straight back to the bed and do an assessment. And sometimes we get like a neuroradiologist who immediately looks at the scan, and then you get like a telestroke doctor to look at the patient through FaceTime or something like that. That's why we're moving all these things relatively quickly. How long does it actually take to give thrombolytics once you get in the hospital? Hopefully under an hour is sort of the goal. How long does it practically take? I mean, if you had everything spinning up, it's still probably going to take 30, 45 minutes to make all this stuff happen. So you have to have that little bit of lead time. And it's not like it's okay to give it if they arrive at the hospital 4.5 hours after their last known well. It's like the drug has to be moving flowing into the patient within 4.5 hours, something like that. So you do have to be, you do have to have a little bit of lead time for these folks. If the guy arrives at 4 hours and 25 minutes or 2 hours and 55 minutes to the hospital, he's probably not going to be able to get thrombolytics. We can talk about the effectiveness of it, and well, we won't talk about it. I'm just not going to enter into the discussion because I don't know all that well. I know that stroke doctors seem to still like it, and I have to kind of defer to them on it. And again, that's up for debate. So there's thrombolytics, which are relatively easy to do and relatively widespread. And then second, the treatment for especially the large vessel stuff is thrombectomy, physically going in and getting the clot out of the guy's head. A couple of different ways you can do that. This is two examples. These guys have got a little, you can imagine being up in somebody's brain, that picture on your left. They'll go up with a little suction catheter and you see the little clot getting sucked out behind it. That's one way to do it. They've also got these stent retrievers. Basically, they go through the clot and then they put up a stent and drag either stent the thing up or depending on what it is, drag the clot out behind it. Thrombectomy takes a lot of people. It takes specialized people to make it happen, and not everybody can do it. In fact, most places can't do it. Most places can give TPA. Most places cannot do a thrombectomy. You have to get to the big centers like the TSC, the Thrombectomy Capable Stroke Center, or a CSC, a Comprehensive Stroke Center. Most community hospitals are not going to have this option. Some do, so you have to know where you're going ahead of time. But the nice thing about this is you pull out the clot. Things seem to get a lot better even up to 24 hours after the last time they were known well, or maybe symptoms began. You have a lot more time to make that happen, which is good because, again, you usually have to get them transferred to a very specific center in order to make that happen. In the state of Kentucky, for example, here are counties with primary stroke centers or acute stroke ready hospitals, which are basically, they have a means, a plan in place and rapid consultation with a neurologist or a stroke doctor. That's what kind of an acute stroke ready hospital is. And then primary stroke centers basically are like a level 3 trauma center, and a comprehensive stroke center is kind of like a level 1 trauma center that has all the stuff. I digress a little bit. But here are the counties that have the counties, not the locations, of places of stroke centers in Kentucky, for instance. And there's not that many of them across the state. You notice most of them don't have them. They don't even have acute stroke ready hospitals, which is another level of it. When you get down to the thrombectomy capable centers or the comprehensive stroke centers, the place that can actually get these clots out, like go in and physically grab them, there are 2 of them in Jefferson County. They are that close. There are 2 of them in Fayette County. They are literally on top of each other. Like if you were flying in a helicopter, you might accidentally land at the wrong comprehensive stroke center. It's very possible. And then there's a couple of them north of the river for folks in northern Kentucky, and there's one in Indiana, kind of down around those parts. Don't get me 100% on the geography of it. But there's not that many places, especially if you're kind of south, west, east. There's not that many places that offer that service available for most of these folks. So for most of us, most folks that show up, they're going to be looking at the TPA sort of candidate. But the one difference that it can make, that the treatment that you are interested in terms of time and size, is that it kind of determines how much diesel fuel you're going to use, or for that matter, whether you are going to use diesel fuel or jet fuel for this person. The treatment of stroke in the pre-hospital setting, other than doing the basic ABCs and doing the good identification, is getting the right patient to the right place at the right time and within the right time so they can get that treatment. Because not everybody is appropriate to go straight to a comprehensive stroke center or to go to a thrombectomy capable center. Some people really, really need it. So who goes where? There's a little bit of guidance on this. For the most part, pretty much all the guidance from like Stroke Association and AHA and all that kind of stuff, all the recent papers that are out there, and we'll hit on it in just a second, mostly says, think first, you try to get them to where they can start getting TPA for their stroke first thing. So if that's a local hospital, if they're going to go outside the window, if you take them any place but the local 6-bed emergency department, then you should take them to the 6-bed emergency department. Preferentially, you try to get everybody to the bigger hospital if it's available to you. But for the most part, if you go where they can get TPA within that time window. And how long does the hospital need? You got to talk about that with the hospital first. The time to not be figuring that out is when you got a patient in the back of the ambulance and you're wondering whether to drive 5 minutes or 35 minutes or to call a helicopter. You got to sort that out ahead of time. So you should go where the patient can get TPA in the window. That's the big principle number 1. Now we can kind of get into some of the specifics a little bit. So for the most part, the guidance is if there's no large vessel occlusion, they are only dizzy, or they have numbness in their arm or something like that, but they don't meet any of the LVO screening things based on whichever scale you decided to use. They should go to the closest stroke center, if at all possible, or a place that they can get TPA started. And for the most part, generally speaking, again, you got to talk to your local hospital. For the most part, that's most places that have a CT scanner and somebody to push the button on the CT scanner. Generally speaking, folks should be able to get TPA started at most of those places. Again, check beforehand and make sure. Slight pause, sorry. So if no large vessel occlusion, but they seem to have a stroke, going to a stroke center would be great, or a place where they can get TPA started is the primary thing. Now, what just came out was big recommendations on regional stroke destination plans. This is how you set up, where do we tell our people to go as a medical director, or if you're a service director, a clinical person, where do we tell our folks to go? Here's what it's based on. It's mostly based on if you are presumed to have a large vessel occlusion, because we kind of talked about the other ones. You need, if they don't have a large vessel occlusion, you should probably start them at whatever place can get them the TPA the fastest. So figure that out ahead of time. But if maybe it's a large vessel occlusion, it sort of depends on if you're in a rural setting, a suburban setting, or a urban setting, depending on to determine what it is. So let's look at the urban setting recommendation first. This is, again, straight from that paper. They say that if you're in a rural setting, if the time from the scene to a comprehensive stroke center or a thrombectomy capable center is less than 60 minutes, then you should go there. Oops, I'm in the way, sorry. So go to there if it keeps you in the TPA window. But there's a little bit of a caveat. in that if you have to drive past a primary stroke center or an acute stroke ready hospital, someplace that has kind of a neurology bent to it and a neurologist that can look at the patient or something like that, and that we're sure is going to get TPA, it should probably be, you probably should go there if it's going to be more than 30 minutes to get to the comprehensive stroke center. What does that mean? Basically, it's probably better to get to the closer place a little bit faster, start getting them some lytics so that you start getting blood flow back to their head, theoretically, hopefully. So if it's more than 30 minutes to the comprehensive stroke center, you can take them to a primary stroke center. And the time when you would really only stop for a local hospital is only if it keeps you within the TPA window. Not ideal if that's the case. So if you've got 40 minutes left in this person's time, then maybe you need to stop at a local hospital and they'll transfer them from there. But for the most part, if you're within 60 minutes of a comprehensive stroke center and you're in a rural setting, you should probably try to get to that comprehensive stroke center. They make a little bit different recommendation if it is in the suburban areas. So in this case, instead of 60 minutes, they say 45 minutes. Same rules apply. If you have to drive more than 30 minutes past a primary stroke center, then you should stop at the primary stroke center. And again, if you have just a very limited time before the patient cannot get TPA anymore, then you should probably stop at the local hospital first. But that's kind of where it gets laid out. And then in an urban setting, and this one doesn't make a whole lot of sense to me because it overlaps a lot. Basically, if you can get to a comprehensive stroke center or a thrombectomy capable center, the big center, within 30 minutes, you should take them straight there. Otherwise, stop at one of the smaller level stroke centers, or again, a local hospital, only if you can't get someplace better, and keep the patient in the TPA window. Make sense a little bit? It's one that you kind of got to think about. And again, not one that you're going to figure out in the ambulance itself. But when you're sitting around a boardroom or a table or something like that and figuring out these plans for your service, it makes a little bit more sense. But for the most part, the service has got to develop a policy in terms of where we're going to take these folks so that you don't have to try to figure that out in the field when you've actually got the patient in front of you. Worth mentioning too, that it doesn't necessarily have to be drive time. You can involve air medical resources in these patients and probably should if it will get the patient there faster. But do think about the overall time. It's not, again, 60-minute drive time to the next center. Is the patient going to get to a CSC, a comprehensive stroke center, within 60 minutes? Not just what the actual physical distance is. So if you think about sometimes our responses from the air to scenes, depending on where you're at, if you are out in a rural area especially, from the time that you identify the stroke and call for a helicopter, let's call that 10 minutes until the helicopter actually launches, including the weather check and everything else goes with it. Let's call that a conservative 10 minutes. Let's call it 10 minutes to the scene. That's, again, a conservative estimate. Or best case scenario, probably. There's probably about a 10-minute scene time to land, assess, load, do all the stuff, and then take the patient away. And then it's probably at least another 15, 20, maybe more minutes to the comprehensive stroke center where you're actually trying to take the patient. And so bear in mind that you do burn up a lot of that time. Now, it may be possible that in your situation that air medical is the best way to go because it will allow patients that otherwise wouldn't be able to get to that comprehensive stroke center to get there in a expeditious manner. And there may be a time savings to it, but do bear in mind that as you are calling for a helicopter, that there's going to be some spin up time behind it. There's going to be some handoff time by it. There's going to be some assessment time, and then they actually got to get to the place. So you may save 15, 20 minutes, and 15, 20 minutes of neurons is nothing to be ashamed of. That's whatever it is, 15 billion neurons or whatever the neurologists say you lose every minute. But at the same time, it's also not like a 5-minute thing. It's not a small endeavor to make that happen. So again, figure that out ahead of time and don't leave it for the poor guy who is on scene in a snowstorm trying to figure out what his stroke destination plan is. All right. That's where the people should go for the most part. There's one question that I wanted to answer, and I'm talking way too much. I'm sorry. Should I mess with the patient's blood pressure? This has come up a couple of times. We get calls about this. We have a patient that we think has a stroke and his blood pressure is 210 over something. Should we give him some sort of medicine for it? Should we lower that blood pressure? This is sort of a little bit of a tricky subject. When we get, I'm just going to skip over some of this stuff here. Let's get down to the brass tacks. When the person gets to the hospital, again, we're going to be thinking, okay, stroke TPA, we got to make that happen. TPA comes with it a little bit of a caveat in that their systolic blood pressure generally should be under 185 is the recommendation before they get thrombolytics for stroke. Now, a lot of people with stroke are going to be hypertensive. Well, I can't remember the exact number, but basically most people get at least a blood pressure over 160 within the first 24 hours when you have an ischemic stroke. The majority of people do. So getting that blood pressure under 185 sometimes can be a little bit of a challenge, and people fall outside the window sometimes because we're just messing with their blood pressure so much we can't get it down enough to be able to quote unquote safely give them the TPA. So if we started doing that in the field, would that be better? There's not a lot of like great recommendations for this, because you do run the risk if you medicate these folks that they become hypotensive, and then their brain, which was used to this high blood pressure, all of a sudden has less pressure behind it, more area gets ischemic, you lose some of the collateral flow, et cetera, et cetera, et cetera. So generally speaking, we try to let these people run fairly high on their blood pressure, but if they're getting TPA, you do want them under 185. The best I can tell you, and this is a recommendation from Walt Lovers MD. This is not the people I represent or any specific place. This is just kind of what I think I would do as in terms of medical direction. It's probably reasonable if you are somebody that deals regularly with antihypertensives like labetalol or nicardipine, or if you're a helicopter service, it is probably reasonable to try to get these people's pressure pre-hospital somewhere between 160 and 185. And the only benefit to that, acutely probably, is that it is then low enough that they could get TPA faster at the receiving facility where you're going. Now you got to talk to the facility ahead of time. They may say, don't mess with it. We have different plans. We don't want you to screw around with it. But if in absence of any other guidance, it seems to me a reasonable thing to say, if you got them between 160 and 185, that's probably about a 15% drop for most really hypertensive people. So it's not too bad. And it does get them down there a little bit faster. But again, talk to the place ahead of time and figure it out. And if you got to make a decision, don't aim for normal blood pressure. Don't aim for 120 over 60 on these folks, because you ain't going to get it and you're going to hurt them in the process. One last thing here, and then I'll stop talking about strokes. I thought I would just put up the kind of spiel that I give to folks. We've been talking about thrombolytics a little bit and how you take people to an emergency department to get thrombolytics, and it's all based on that. What do you actually tell people about how effective this stuff is? Well, the typical stroke thing that I have when I'm talking to somebody about it, after we've gotten CT scans and finger sticks, we got their blood pressure okay, and now we're going to say, all right, should we give them this clot-busting drug that has a not insignificant amount of bleeding that occurs afterwards, sometimes fatal bleeding? How do I talk to people about this? This is a good spiel, and this is a good graphic. So I usually tell folks that out of 100 people who seem to have strokes, likely, and get thrombolytics, 32 of them end up at least a little better, and some of them end up almost completely better. We don't know if that's the drug or not, but that's what happens. About 65% of them will stay the same. I usually don't tell people we don't know that's because of the drug. I just phrase it this way. 32 will end up maybe a little bit better, or sometimes a lot better. About 65 of them, 2/3 are going to stay the same. 6 of these folks will have significant bleeding. 3 of the people will end up a lot worse than they were, and 1 of those people will die. Out of all the folks that get this drug, those are the statistics. And we kind of leave that up to people. Now, again, there's a lot in there. You can argue about the effectiveness and the reevaluation of the NANDS trial and blah, 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 blah. But this is the data that we kind of got, and this is what the stroke guys go on, and this is what the system says. And I think, generally speaking, we're good to tell our patients these are like the things that happen, but and the risk kind of behind it, and just what we've observationally seen, if nothing else. So without taking a hard line one way or the other, this is what you tell folks. And this is so that you have an idea. About 1/3 of these folks will get a lot, at least somewhat better. And if you are completely paralyzed, that sucks. Even getting some motor function back in your arm, that may be a really good thing for somebody that's had a stroke. So now and you kind of have an idea about the effectiveness of it. So let's hit the summary real quick before we take another break here. And I, again, apologize for being so long-winded. All right. You should do the Cincinnati Prehospital Stroke Scale, or a FAST, or whatever scale it is that you're doing to try to identify a stroke to start off with. But you can't trust anything other than an acute sudden neurological change as a sign that this could be a stroke. So even if they have a normal FAST, face, arm, speech test, if they had a sudden neurological incident, you got to be thinking this could be stroke, and treat them accordingly for at least what we're going to do. After you do that, you should do a large vessel occlusion screen, whichever one you want to do, whichever one you are able to do well is fine. They're all mostly end up pretty much the same, but it's the best one is the one that you do. Make sure you find out their last normal time, get a finger stick on anybody that looks at you cross-eyed, and then, for God's sake, don't leave it to the poor guy in the field to figure out where and how you're going to get stroke patients from the middle of your county before you get the call. Make that a policy, make that something that is fairly clearly laid out, not something somebody has to figure out in the field.